Disclaimer: this video is solely for educational purposes. No financial interest involved. Topic is Open Globe Injury Management, Visual Rehabilitation by Secondary Cataract Surgery in Tertiary Care Center. A 12-year-old male presented to IOPD due to trauma by corner of bed since one day. For this, emergency OT was planned on the same day for primary repair of open globe injury under general anesthesia. This is the corneal laceration planned for the primary repair. Side port is being made using 15-degree lance blade at 2 o'clock position. AC is formed using viscoelastic. The area for primary repair of corneal suture is being prepared. Corneal suturing is started using 10-0 nylon with reverse cutting needle following adequate depth and distance from the injury. Sutures are tied and locked using 3-2-1 technique as depicted in the video. Anterior chamber is maintained throughout the procedure. All knots which were formed are now buried. Anterior chamber is washed using Simcoe cannula. Here, the membrane of varying density is detected, which is thoroughly separated using iris repositor and finally removed. Anterior chamber is washed using Simcoe cannula and air bubble is injected to form anterior chamber. Side port is hydrated. Then, using tryptan blue dye 4 mm distance from limbus is marked in view of vitreous tap for gram staining, bacterial culture and KOH mount, but the result was found negative for all of three. Calipers measure 4 mm distance from the limbus. After that, intravitreal injection of ceftriaxone and vancomycin are injected separately from pars plana. Air is injected to form anterior chamber. Side port is being hydrated. To prevent the collapse of anterior chamber, side port is sutured using 10-0 nylon suture as depicted in the video, and after that the knot is buried. Now the case is being closed. This is the final outcome of primary repair of open globe injury. After 2 months, visual rehabilitation for traumatic cataract was planned. For this, firstly the side port was created at 11 o'clock position and then at 4 o'clock position using MVR blade. After that, air is injected and anterior capsule is stained by tryptan blue dye followed by anterior chamber wash and injection of viscoelastic substance to form anterior chamber. The posterior synechias which were formed are cautiously broken down by this swiping movement. After that, anterior chamber is formed. Main port entry using keratin knife is done. Continuous curvilinear capsular rhexis is performed using cystiotome needle, and here extension of the rhexis margin is noted. So the measures were taken to prevent the extension of rhexis margin posteriorly and for the successful completion of the continuous curvilinear capsular rhexis for intraocular lens placement in the capsular bag. Kindly note the steps of lens aspiration of traumatic cataract which are depicted in this video one by one. Limited hydrodissection was done because we were not sure of posterior capsular integrity in traumatic cataract. Since the child was of 12 years of age and there was no nucleus present, so the lens aspiration surgery was done by Simcoe cannula. Once we were sure for the posterior capsular integrity, we performed the lens aspiration by bimanual irrigation and aspiration cannula. Anterior chamber is formed. Now, the preloaded hydrophobic posterior chamber intraocular lens is being implanted in the capsular bag. Proper centration of intraocular lens is being ensured. All the remaining viscoelastic substance is being aspirated by bimanual irrigation and aspiration. Air is injected to form anterior chamber and the case is closed by side port hydration and subconjunctival injection. After 45 days, all the sutures are removed under topical anesthesia one by one, as we can see in the video. This is the picture of the final outcome after suture removal. Finally, the visual acuity of eye injured is 6 by 24, which is best corrected by 3 diopter cylinder at 180 degree to 6 by 12. The outcome is unexpected as visual prognosis of open globe injury is poor. In the anterior segment photograph, we can clearly see the scar mark on cornea and clear central area in the posterior chamber intraocular lens implant. This is the story from trauma to triumph. The personalized approach of our surgical team for visual rehabilitation after open globe injury brought renewed hope, joy, and satisfaction in the patient's journey towards normalcy. Thank you for patient listening.